Hi, I am Dr. Deeksha Pandey and I have one very special person today with me, Dr. Sreelakshmi. Sreelakshmi is Assistant Professor in the Department of Clinical Psychology and she has been working with us in our Urogynecology or Integrated Urogynecology Clinic for now almost 3 years. We are working together. So today we'll be having a little chit chat about her viewpoint. First thing I want to ask you, like you have been working in clinical psychology area for a long time and for last 3 years you are working with us. So what do you feel like when the patients come to clinical psychology, actually they ask for it. They know that they have that insight that they have a problem and then they come to you. When they come to us, they come for a physical ailment, but we send them to you. Okay, so what do you think is the difference in this kind of interacting with patients? Do you think is there a difference?
Yeah, I think, ma'am, certainly there is a difference, but I would also say that though when you send them to me and when I explain to them about how their mind and body are related and how when they have some worry about their condition or when they are sad that they cannot go out and interact with others, and help them see how that would be contributing to their physical ailment. So that's my first job there. And once I then get talking to them, then they understand the relationship, then they ease in and then they talk to me.
So it's not big trouble that they are thinking that unnecessary we are doing that. They understand it after some time. Okay, the second thing is like, do you really feel when you have started working with us, do you really feel that the kind of problems, okay, first I'll ask you what kind of problems you'd see, especially in urogynecology, if you have to categorize like depression, anxiety, what are those problems? Can you give me an idea that most of the times, what kind of problems do you see?
Yes. So after working in our clinic, what I have seen is mostly they have a worry about their condition because this when people come to us with urinary incontinence and prolapse and all, they would not have shared it with anybody. So, and there is a sort of shame also attached to it. They feel very bad to go out because they think they'll be smelling of urine and need for increased maturation and things like that. So there is a worry associated that I've seen. Also, because there is lack of mobility, they don't move around and interact with people. There's some amount of low mood also that I've seen in them.
Another low mood means depression kind of thing?
I wouldn't call it a syndromal depression per se, ma'am, but I have seen low mood in them. They feel sad. There's no crying or anything like that, but they feel sad. They feel unworthy about themselves. They are not interested to do many other things that they used to enjoy earlier. So those things come up. Another thing that I have seen in them is sleep disturbances sometimes, because they sometimes have to wake up in the middle of the night and go and urinate and come back. And when this happens multiple number of times, especially with our patients who are older in age, it sort of disturbs their sleep also. Another area is with respect to their sexual life. So because during intercourse sometimes they leak, there is a urine, so they feel very bad about it, they feel unworthy again, and then they have all these thoughts about what would my partner be thinking about me, would he not like me anymore, would he reject me, so in that area as well. So these are the 4 areas.
We call it something self-image.
Yes, self-esteem, self-worth actually, self-worth actually goes down, because in women it's a lot attached to their womb and their it sort of questions their femininity as well. Yes.
So one more thing, Sreelakshmi, I think if you have to compare, by chance if you have to compare the kind of patient, let's say general population, we are saying that depression is increasing, anxiety is everywhere, you open internet, there are thoughts about this thing. But do you think that if we have to compare in general population, what is the level of these kind of psychological issues, may it be anxiety, worry and all? And if the other group is this cohort where we are seeing urogynecology patients, do you think it is almost the same or is there a difference?
I wouldn't think that there is lot of difference, ma'am.
Okay.
But people who already have a diagnosable psychological issue, in them, when they have these issues also, I've seen them being exacerbated even more. So that I have observed in our patients. So who are already on treatment for anxiety, or who has got anxiety as a trait in them. In them, when this also comes up, they start worrying a lot about their health and whether this would improve or not improve. And again, they don't discuss it with anyone.
More.
Yes. In them, it seems to be a little more exacerbated.
Is it possible, Sreelakshmi, that it is a consequence rather than the effect of that? I don't know. Maybe the cause of that. Maybe because they were developing this worrisome urinary problems or other pelvic floor disorders. Maybe that time they started getting into this. That was the cause of depression. Is it a possibility?
I have seen anxiety even when patients who did not predominantly have any anxiety.
And maybe when they come to your clinic also, or not for urogynecology also, when they go for psychological counseling, they think that both the things are not related. Maybe the anxiety started, the depression started when they are having all these problems. They were like not going into social life, then remained into themselves, then depression. But when they go finally after years to meet a psychologist or a psychiatrist, they do not realize, they do not want to tell those problems because they think that those are disconnected.
Yes. So just because people have had these urogynecology problems, it certainly has led them into worrying and low mood, like I already said. So that I have definitely observed in our population. Yes, people otherwise were having very healthy sexual life and sexual practices that go for a haywire after they realize this. And main issue again is they don't come out, they don't talk about it, and when they go to somebody else who is not informed about these issues, then they just brush it off, saying that it's okay, it happens in all females, and many of them do not know there is treatment available. So that again leads them to think that, oh, I should not be talking about, I'm making a big deal out of something that is very common, very normal. So that again leads to a lot of guilt and shame, and self-worth goes down very badly. Yes.
So one thing, like many people, before meeting you, I thought that I am a very good communicator. I thought so, that I can make good rapport with my patient. And I used to ask, sometimes they will tell me one or two. I thought if I'm like patient, I'm listening to the patient, they will tell me everything. But now I realize, Sreelakshmi, that it is not the same thing. Your approach is different. See, when I focus, I can take a very good history and I can make a diagnosis of a physical ailment. But I'm not trained to do the psychological evaluation. So I think many people like me, like I used to think before, might be thinking that they can extract. They do not need the help of a psychologist. They can get all the information. But now I really realize that I would have asked patient some questions. She would have replied to me. Then when you see and when we start discussing the case, there are so many new things you tell me, that this is also there, that is also there, which I never thought and she never told me. So do you follow a protocol? Is there a different way of asking and doing some hypnotizing in patient that they tell you everything, they don't tell me all those things?
I certainly do not hypnotize them. But I think, ma'am, again, it's a training that I have got, like you said, in our masters also and in MPhil also. We are taught to interact with our clients in a particular way, and I think it's all about how they feel comfortable with us, and then how that rapport is formed, and they slowly trust us, and then they understand that okay, she would understand what I'm saying, and then
and maybe there is no mix of physical. One time, like as a gynecologist or a urogynecologist, sometimes I'm asking that question, then suddenly I'm jumping into another. So maybe they're confused. When you sit with them, you ask one area, I ask one area, so maybe patients are more focused.
And like I said earlier, ma'am, when you sent them to me also, they come to me with a trust
Yes.
that their gynecologist has referred, and then it's not like ma'am do not get everything out of them, she does. And that so they sort of come with that openness also.
Yes.
And it's all about helping them see, understanding the need, why they need a psychological help, and that they can trust me, and then things that they tell would be kept confidential, and it's going to go, not going to go around and then other things. So I think that's what helps me.
So for like maybe some psychology students are listening to that. So do you think that a general psychology training is okay, or do you think that you have to have a different training, or like if you have to deal with these kind of patients specifically? Suppose somebody wants to work in a urogynecology clinic and get attached to one person. Do you think they need a different kind of training, or it is just like dealing with any other patient the way you do it?
Yeah. When I came to urogynecology first also, ma'am introduced me to an area that I was not very familiar with earlier. Because like I said earlier, these are not things that people talk to you about.
Yes.
Even when ladies come to us with certain problems, we do not ask for these issues because we do not know.
No.
It is a highly specialized area.
And like that, there can be 100 issues. What all you can keep on asking?
Yes. So because we our brain do not know it, we do not see it, eyes do not see it. So what I would feel is, ma'am, this type of a sensitization, and it's a very common issue that most of the females face also. So a sensitization about something like this would certainly help a psychology student, or a psychologist for that matter, to ask questions pertaining to this area, so that they also would be able to see the relationship with it. To give you an example, ma'am, a patient with obsessive compulsive disorder, OCD, who has excessive washing of the genitalia, we do not often ask them about their urinary incontinence that they tell us, and whether about a prolapse that they are having. After I started coming to the clinic, when I started asking my patients about it, that's when I understood that majority of them have it. And that I was able to see the relationship between their OCD and these things as well. So once I refer them to you and you take care of the other part, the symptoms here also come down. So that sort of a sensitization, I would definitely say, is needed for them.
Then the second thing, Sreelakshmi, do you follow any protocol, or it depends on patient to patient basis how you are going to, like most of us when we interact in gynecology or urogynecology, or last time I was talking to Preeta, they have a set protocol, they do this, they do that. Or clinical psychology also is like that, or you based on patient's mood and what kind of patient you change your thing, or there is a set protocol, set tool, stepwise approach to do that?
Not exactly, ma'am, because in psychology, though we have protocols, no protocol works for all the patients, because it has to be tailor-made for the patient. Because even though 2 of my patients would be having depression, their depressions are different. I have to treat both of them differently. So I tailor make it for the patients who are coming to us, depending on their age, their family background, the issues they have come with, and the personality they have as well. So once I get understanding of these things, then I modify my approach accordingly. So some of them already, when they come, I can see that they're very anxious. So I probably would have to, before doing anything, we'll have to ask them about their anxiety and help them calm down a little bit, maybe teach them deep breathing, and then make them feel comfortable there. Sometimes they are okay, but their worry is only about, will I get better? And ma'am is giving me medications, but will it be helpful for me? So maybe I have to help them around that area. Sometimes it is adherence to medications and exercises that they have been given or taught to. So sometimes it's that, and sometimes it would just be listening to them, helping them ventilate, and lending a ear to them, so that they sometimes I've seen that it's for the first time that they are able to talk to somebody very openly, especially when it comes to sexual problems and all. So sometimes when I ask them, that's when they say that, oh, it's first time that somebody is asking me about this, and then somebody is understanding that it's an important issue that is there in their life. So I usually tailor make it for them.
So exactly what you said, that this genital prolapse specifically, or any other urinary continence also, before we treat, like, we think so many things. We think, okay, this is the anatomical defect, this is the age of the patient, and this kind of activity, this kind of occupation she has. But one thing which we usually forget is about her sexual life. Like, we might be trying to give, maybe the patient has, she has not told, but her prolapse might be bothering her only because of during sexual intimacy. We are not treating life-threatening conditions here. We are just trying to give a quality of life to patient, and it's not that what is your definition of quality might not be her definition of quality, isn't it? What kind of treatments you offer to these patients? Like, when you do not, I believe that you do not write too many medications for them.
No, because I am a clinical psychologist, so I do not give any medications.
So what is your way of treating them?
Like I said,
some modalities.
Yes. So usually I take a very person-centered stand, very supportive stand with them, because not all of them who come to urogynecology also would need a psychological evaluation, though we see all of them. So people whom I feel would require a little bit more work cognitively, I call them back. I follow them up on their later follow-ups as well. So usually I take a very person-centered, supportive work with them.
I have seen.
And then usually a little bit of cognitive work I do if it is needed, and if there is any need for relaxation, teaching relaxation exercises, then I do that. And also talk to them about the importance of self-care, importance of taking care of themselves along with their family, because ladies prioritize everybody else and then they do not take care of themselves. So I often have to talk to them about it, the need to prioritize their life also. So that's another thing that I do with our patients. And sometimes, very rarely also, I have seen patients who because of this condition, when they have come to you after a long time, after having had a prolapse for many years, and then in the final stage when they come, we see that their bodies are very tight. And then even when I've seen when Preetham is trying to teach physiotherapy, they're not able to relax their body. So sometimes me and Preetham work together, and then maybe help them in understanding how to relax their different body parts. So sometimes we do progressive muscular relaxation and then do it. Tell patients to practice it for a few days, and then Preetham starts the physiotherapy sometimes.
I know.
So sometimes we work on that way also.
I think that's very important.
Yes. So I think it's, I don't work separately or exclusively. We work as
together,
a team.
as a team.
Yes. And that I think has helped quite a lot. Yes.
So one thing, maybe this is the last question I'm asking you. Okay, do you think that sometimes there is a need to counsel patient party also?
Sometimes I have done that, ma'am, especially like you said, when it comes to sexual problems. If my client tells me that my partner is not supportive and that is not understanding of what my condition is, then in such cases, with the client's permission, maintaining the confidentiality in other aspects as well, I have spoken to the party, the spouse or whoever. So it's very important that the family is also sensitive to the issue that the woman is going through, because when she is leaking or why she is hesitating to come out and take part and interact with others, why is she avoiding traveling, these are things that the family should be sensitive about.
Very important. I think this is a very important point that we all should understand. I'll tell you, one of my colleagues, she told me a story. There is a family of her relative, and in that lady has problem of stress urinary incontinence. Her children, her daughters and sons, they make fun of her that, okay, if they're about to crack a joke, they tell, okay, mama, you first go to washroom, then we'll crack this joke. So it is a like first only patient is at such low
Yes,
self-esteem, suffering with a physical ailment, and then you are making fun rather than taking care of her, rather than taking her to hospital. I think it is a very, very bad approach.
Yes. So while interacting with clients, I also make it a point to inquire about how the family is taking it, how the family's approach is towards her, to the problem that she is knowing. She is having. But most of the times what I've seen is they first of all don't know what her problem is.
Yes.
Sometimes they don't know she has a problem also.
Maybe they think that it is just a deviation from normalcy. If she's going to pass urine many times or with certain things, they think that it is a habit. They don't think it is a physical ailment which needs a treatment.
Yes. So once the family is sensitized, they understand, they become much more sensitive while interacting to the patient. And I also tell them about when they talk to her, like you said, the remarks that they make. It's not the lady's fault that she is having this issue, and it helps them understand that okay, it's not something that she should be blamed for. It's like any other ailment that she is having.
And maybe the children who are making fun, they only have to be blamed because while giving birth to them, maybe she got this pelvic floor injury.
Yes. So helping them understand her condition and the causes and prognosis and the difficulties that she is facing because of this, that sort of helps the family and helps the spouse also when interacting with the client. Yes.
Wonderful, Sreelakshmi. It was very nice discussing all these small little things with you. And what I think that this is the first, what do you call this, like first warm-up session with you. Maybe what I was planning that maybe sometime we can select a patient and my PGs, your PGs and PGs of Preeta from physiotherapy, maybe we can take one patient and discuss it all together to tell how our team works and what kind of holistic management with everybody's approach, how we manage our patient holistically. I think that will be quite interesting.
Definitely.
So thank you so much, Sreelakshmi, for your time.
Yes, thank you so much for inviting me also, ma'am. Thank you.